This is the Head Rush Podcast with Paul Fraze and Corey Berry.
Welcome to the Head Rush Podcast. I'm Paul Fraze, and I played 11 years in the NFL, and our co-host, Corey Berry, rode professional rodeo for 9 years. At the Head Rush Podcast, we talk about everything related to brain trauma and brain health and wellness. We talk about traumatic brain injury, TBI, chronic traumatic encephalopathy, CTE, traumatic encephalopathy syndrome, which is the closest you can be diagnosed to CTE while you're alive, and repeated head impacts, RHI. We cover how traumatic brain injuries can and will cause mental health issues such as depression, addiction, lack of executive function, memory loss, even suicide ideation, as well as degenerative neurological issues. These symptoms can be found on the Mayo Clinic and Boston University websites under symptoms of CTE. Our mantra is how to cope and find hope. And we focus our energy on finding therapies and sharing hope through education and by raising awareness. And we ask you to please help us raise the awareness of TBI and repeated head impacts and repeated blast exposures by liking, subscribing, sharing. This is important and very important information about our brain health and mental health and brain health and awareness. So please like, subscribe, share. We've got two wonderful guests here today. First, Cristal Clark, founder and clinical director of MC Wellness in Fort Worth, Texas. She has a master's degree in counseling from Liberty University. That's where our daughter Isabella went. Cristal is EMDR trained, and much of her practice is focused on first responders, veterans, and now athletes living with physical and emotional traumas. And you don't have to guess, she actually is our personal counselor, Corey and myself. Did I just violate HIPAA or no?
No, you can disclose any information you want.
Okay. Well, thank you.
We have implied consent now.
Okay, wonderful. Thank you for joining us. And please introduce our Nate Pope.
You just did.
Sorry.
Our next guest is Nate Pope from Utah, Provo, Utah, right, Nate?
Yeah, close to it.
Nate Pope is a neurological occupational therapist specializing in innovative brain recovery techniques. As one of the founders of NCX Brain Recovery, he's helped pioneer multisensory integration therapy for concussions, traumatic brain injuries, and post-concussion syndrome. With over 20 years of experience, Nate helps listeners understand cutting-edge approaches to brain health and rehabilitation, offering hope and practical insights for those affected by neurological challenges, especially those dealing with post-concussion syndrome. And his brother, who's not with us today, Justin Pope, is also a neuro-occupational therapist who has helped shape evidence-based treatments that empower individuals to heal and reclaim their lives. His greatest satisfaction comes from seeing meaningful improvements in his clients' symptoms and quality of life. Outside the clinic, Justin enjoys spending time with his family and exploring the outdoors and woodworking. And a little tidbit for our listeners: we all know that I rodeoed professionally for several years. Well, Nate Pope has known Louis Fields and Casey Fields and Veronica and, well, the whole family, right, Nate? And you actually worked on Casey's shoulder, correct?
On his forearm.
Oh,
It's
his
that-
forearm.
Gripping so hard to stay on.
Well, tell us about Casey and the gang out there. I mean, he's obviously a very, very important. Tell us, to somebody who is ignorant, totally ignorant to the world of rodeo, except Corey Berry.
Not except Corey Berry. The whole world knows about the Fields family.
Exactly. They are. They are rodeo, right?
They are rodeo. I mean, you got Louis Fields, who's all-around world champion, one of the greatest bareback riders out, saddle bronc rider, great cowboy, very religious man, one of the most kind-hearted people I ever met. Mm. I actually went to a Louis Fields bareback riding school in Phoenix, Arizona, and then he helped me on later in that weekend at the World of Rodeos in Phoenix. And Louis was a great inspiration for me. Him and Clint Corey, Bruce Ford, Marvin Garrett, Mark Garrett, all of them were great. But Casey Fields is Louis' son, who is a multi-time world champion bareback rider also, and a great man, just like his father. And I just, that whole family, Veronica, I only know Veronica, Casey, and Louie. I don't know the brothers and the whole family, and they got a big family. But it's a very good, religious, strong family.
It's awesome to hear the best of the best, athletically, are also the best of the best, service-wise, family-wise, and they're
emotional, mental,
kind-hearted, very stable, and give you the shirt off their backs, I'm sure.
Right, and you went to church with Louis, didn't you, Nate?
Yeah, yes, I did. Yeah, when he was off-roading, I was, his wife Veronica was there, but he's, for someone who has all the rights to be a proud person, he was also one of the most humble guys you'd ever meet. So I thought that was pretty cool about him. So
that's great. That's great. Well, Nate, a huge welcome to you. We need to, obviously you're a co-founder of the NCX Brain Recovery platform, and we're going to learn more a lot more about what that is, what your system, your protocol is. But we're going to kind of go through, we get asked a lot, because we're a brain health and wellness podcast. We get asked a lot, somebody comes and says, I just got a concussion. What do I do? Do I sit in a dark room, or do I, what's the stimulation that I can handle? Or Johnny just got a concussion 3 weeks ago. I want to kind of walk through what NCX does for the brain recovery protocol. I want as soon as the patient walks in the door, right? But one of the things really, and we're going to go through that, but one of the things you talk about the, I think, let's see, I'm sorry. Let's keep it simple. Let's start off with, what is the difference between TBI, a traumatic brain injury, a concussion? Are they the same thing? And then you guys focus on post-concussion syndrome. What are the differences in those three?
Sure. Well, we'll start with, in the beginning, you get a concussion, and a mild TBI is a concussion. So those are basically one and the same, but there's different levels of traumatic brain injury, and just the term implies that there's injury to the brain. And so an MTBI, lowercase m, TBI, is more of, that's your mild traumatic brain injury, and that's just a concussion where you probably don't have any measurable difference in your brain in terms of like an MRI. If you looked at your brain, it would look completely fine in concussions and MTBI. So those are basically the same. And you have healthy brain tissue, in other words, that's not functioning right. There's some stretching that occurs when you have concussion because of the acceleration deceleration of the whole event. That stretching is actually stretching neurons, and in the process, you will have symptoms associated. People will often have enough that they go get an MRI, and it'll almost always say there's nothing here. The words they like to use is unremarkable, which is kind of rude to our brains, but it's also what you want to see if you get an MRI. There's no tumor, there's no scar tissue or bleeding or any evidence of that. And 90 really high percentage in the 90 percentages of patients that have post-concussion syndrome or that have concussions also do not have any evidence that there's anything physically wrong in their brain, and yet they have symptoms. And so that's a fun talking point, but you basically have healthy brain tissue not doing what it's capable of doing. So the difference between post-concussion syndrome and just concussion is you've moved out of the acute phase of what we call concussion, or just the symptoms associated, after about a month. Technically, they start diagnosing after 3 months, but really there's very little change if you look at the research between 1 month and 3 months. And so that's when your brain has failed to reset. Like most concussions, in a few days to a few weeks, your symptoms reset. And even without therapy, often you just recover and you're totally fine. It's about 75 to 80% just recover. But that's still a pretty high 25 to 20% that have lingering symptoms. And if you have lingering symptoms post 1 month, then I would start thinking, okay, my brain's in the habit now of not working properly, and it's maybe going to stick now. Because after a month, those symptoms tend to stick around and they're a lot more stubborn. And so that's post-concussion syndrome. And 20 plus years ago, nothing out there. Like, all the doctors would pretty much say, look, we'll try to do some rehab, but you're most likely going to have these symptoms. They're going to stick around, especially your more severe cases. But now it's something that's very treatable. Most of our patients make full recoveries. So it's a pretty awesome turnaround from where we were to where we are now.
So you look at someone like me. I've had several concussions in my life. But in 2022, I got in a massive car wreck. Hit a tree head on at 65 miles an hour. For 3 months, I couldn't have a light on. I couldn't have TV on. I couldn't have sound around me. Massive migraine for 3 months straight. I mean, massive. I mean, I couldn't tell you from day to day if I was going to be alive tomorrow.
Yeah.
And so when you're talking about these things, the difference between repeated head impacts and a major TBI and all of this, I am clinically diagnosed TES, traumatic encephalopathy syndrome, probable CTE. So someone like me walking into your center versus somebody, little Johnny got knocked out because he's playing football at 8 years old, and coming, are two totally different therapies, I presume.
Yes.
But we're talking about levels. That last wreck, I mean, I'm still suffering from it today on astronomical issues. You could ask Cristal. I still have issues. So if we go through a simulation of a client coming to you, finding out why, and finally ending with therapy and ongoing treatment, But first, what makes NCX different from the standard brain rehabilitation program? Because I went through brain concussion protocol through Texas Health Centers. They did vestibular, they did eyes, they did cognitive and therapy.
Mm-hmm.
And I went through that. I think I did 2 or 3 times a week for like 8 weeks. What's the difference between something like that and what you do? And walk me through how you see a client or a patient and what happens.
Sure. Do you want me to first tell you what we do if a patient has just come in and they've just had a concussion in that acute stage?
Right.
Okay. So and this is especially for, your young athletes, but really it's anyone who's just had a concussion. If you're within days of your concussion, what you don't want to do is cocoon. So first thing we try to do is we want to help people avoid actually coming to us, which is not very great marketing. But most of the post-concussion patients we work with could have probably avoided that if they had done the right things, or at least a high percentage of them could have avoided having the persistent symptoms had they done the right things in the acute stage. When you've just had a concussion, what you need is blood to the brain. So you need via cardio. So you want to do cardio, but you can't do jarring cardio. Jogging is even too much. So it's more like stationary bike, swimming, elliptical, things where you can get your heart rate up, get some blood to the brain, which brings fresh oxygen. It's what the brain needs at that time. Cocooning, which is what they almost always did in the past, and unfortunately it's still what they often do, if they don't know better, is they say you just need to go rest, don't do anything, and maybe a dark quiet room and just take it easy. So right when the brain needs the stimulation to re-engage areas that have become a little less active, because when you get a head trauma, you're stretching the axons of those neurons, you've disrupted some neural pathways, and what you need is enough stimulation to re-engage those. But what happens if you cocoon or go in a dark, quiet place and do nothing is you just deprived your brain of any stimulation to reset in those areas. And so you're way more likely at that point to have persistent symptoms stick around and have your concussion turn into post-concussion syndrome. And so what we tell people is you need non-jarring cardio, get blood to the brain, and then you need to be getting stimulation visually. Your auditory and verbal processing needs to be engaged. Your cognitive needs to all be engaged. It all needs to be a chill level, though. So you have to take it down a notch. If you're a student or you have a job, you probably don't jump back into school or work because it's just too much. But you do go for a walk outside and maybe talking to someone while you go for a little walk, so that anything outside is way more visually stimulating and engaging because of how much depth you have to process. There's just so much going on. You don't have a screen or a wall that limits your ability to converge and diverge visually. And so you want to go outside. Also, there's sounds, smells, and all of the vision stuff. And if you walk on uneven terrain, like maybe in a park, on the sand, if you can go on a trail that's not a big incline, going for walks or hikes outside while talking would be some of the best things you can do in that acute stage after concussion. And then get on the stationary bike, because at least once, preferably twice a day, you want to get your heart rate up with non-jarring cardio. So that's what we mostly tell people when they're coming in. We kind of tailor things to the individual as well, but those are some generalized things that someone could do. They'll be way better than going in a dark, quiet room and doing nothing. So that's in your acute stage. someone comes to us and they're post 1 month and they have symptoms that have stuck around and they're not getting better. This is post 1 month, but it's years, months or years, maybe 20 plus years even, since someone had a head injury and they've been suffering with symptoms and have just barely discovered someone that can work with this. So we deal with a lot of different people at different stages of post-concussion syndrome. But at that point, what's happened is the areas of your brain that have disengaged, and we know that they do this because of effective functional MRI results, which is more like a video of your brain while you're doing cognitive tasks, rather than a snapshot of your brain when you're doing nothing. That's a normal MRI. And that'll look at scar tissue and blood, brain bleeds and, lesions or other things like that. So an MRI is important to rule things out. But when it comes to concussion or post-concussion syndrome, you really don't get a lot of information from an MRI. Usually you get zero information. So your symptoms are going to tell you a whole lot more. And in the research, the functional MRI, like the video of your brain, is what helped them realize that when you are concussed, parts of your brain disengage and get less blood flow, probably related to the stretching of the axons of those neurons. So it's neurovascular coupling is what they call it, but the blood flow changes. And your brain recognizes that change, and immediately other areas are engaged to take over those tasks. So now you have a compensation pattern that's developing. And if you reset in a few days to a few weeks, then that compensation pattern, your brain was able to overcome it and it just reset. And the areas that were less active are now active and they don't need the other areas to help out. But in post-concussion syndrome, for whatever reason, we don't know exactly why, the areas that were disengaged were not able to re-engage, and requiring the other areas of your brain to pick up the slack and to work overtime. And so you'll see on the functional MRI, these areas are getting way more blood than you would ever see for those particular cognitive tasks for someone that was non-concussed. And these other areas are getting way less blood than you would ever see in a non-concussed person. So at that point, you can tell from a functional MRI that way that we're in post-concussion syndrome. The brain has now formed a habit of underworking some areas of the brain, overworking other areas to compensate. And that creates symptoms because the areas that are compensating are just not very good at doing the job that they're trying to take over. They're not designed for those jobs. So it's awesome. Our brain can kind of kick in survival mode and actually help us get things done. Most of us, if we have post-concussion syndrome, can still do everything that we need to do in life for the most part. We're just not as good as we used to be at all of it. And we have all these symptoms to deal with. So our performance has gone down and we have all these symptoms. And so at our clinic, essentially, we are trying to figure out which areas are less active and less engaged. And we are trying to engage those areas so that they become active and everything that's overworking can calm down and doesn't have to. And what they've figured out is isolated therapies are not very good at this. So if you go do, well, people who come in and they say, well, I've done vestibular and I've done vision, I've done speech and I did physical therapy and I've done all of these things to treat my myriad of symptoms. Why hasn't it not helped me? And it's because when you're sitting in the chair doing vision therapy, for example, you're doing the exact right thing for the vision, but your brain is able to continue to cheat and compensate because you're not simultaneously engaging other areas. You're not balancing on anything. You're not trying to process what your body's doing or what you're saying. Your verbal auditory centers aren't being engaged. You're not doing cognitive tasks. You're just doing the vision. And that's same with all of the therapies. They're all doing the right things for that one thing, but because they're only doing it in isolation, it's not enough to engage the less active or the inactive areas. And so we do what is called a multisensory integration approach, which when you're in our clinic, almost 90% of the time, I would say, you are on your feet, doing something, moving your body, challenging your motor planning and your balance. So your brain's processing of where you are in space has to be engaged at a high level. At the same time that we're throwing balls at you, you're having to cross your body to catch the ball. We're trying to get both hemispheres involved, but there's a lot of visual tracking and convergence and divergence with catching balls and moving that way. So visually it's challenging. And then we're usually engaged in conversation and or playing word games so that the auditory verbal centers are engaged. And so we basically do whole brain activities. That's what a multisensory integration activity is. It's how much of the brain can we engage simultaneously so that no area can cheat for some other area. So anything that's inactive is going to have a really hard time remaining so, especially because we also do many hours in a row, many days in a row. Almost nowhere does the right intensity for post-concussion syndrome recovery. We do 7 hours. You're 7 hours in the clinic every day, Monday through Friday, week 1. Most people do 2 weeks, Monday through Friday, week 2. So essentially, you're about 60 hours because you have an hour lunch break in all of those days. So it's about 6 hours of therapy a day for 10 days with the weekend in the middle. That kind of intensity and also doing the multisensory integration approach is what really is engaging brains that have for years even have been, not doing what they're capable of doing. And so,
Nate,
sorry, that's a very long-winded answer to your answer.
Well, that was perfect.
Ladies and gentlemen, this episode is brought to you by Millennium Health Centers, Dr. Mark Gordon at TBIHelpNow.org. He signed on with us. You've seen him in our episode 2 with Dr. Mizell DeMeo and Dr. Gordon.
Dr. Gordon's been featured on a movie, Quiet Explosions, a documentary about TBI. Featured Andrew Marr, a Green Beret blast explosive specialist. And they talk about TBI, PTSD, traumatic brain injury. And I've watched that movie about 4 times. And I know Dr. Gordon has also been on Joe Rogan 6 times. So he has something good and powerful to say about TBI, traumatic brain injury. So go to TBIHelpNow.org.
Correct.
And make sure you get in touch with their team. Dr. Gordon also works with the military. Do you want to?
Yeah, he works with the United States military. He's done the Pentagon. He's working real close with them. If you're a veteran and you need help, go to TBIHelpNow.org. Dr. Mark Gordon quit his private practice just to work with the military.
Work with veterans suffering with PTSD.
Right, PTSD, TBIs, and repeated blast impacts.
Exactly.
And if you are a veteran, there's nothing closer to my heart than the people that serve our country and protect our way of right and our way to be able to do this podcast for you. So go to TBIHelpNow.org and get the help you need. Mark Gordon, we work with him on the Brainwell program through Mizell DeMeo. If you go to TBIHelpNow.org, there's a list. There may be a provider in your area in Canada. He's all over. So go to TBIHelpNow.org and check it out.
Yeah. You're talking about re-engaging parts of the brain and blood flow. Can that happen? 2, you're talking about a multi-sensory integration therapy. Now, it's capitalized on your website. Is this proprietary to NCX? Or do they is that been used in the past? That's 1. Or 2.
Cognitive Effects, wasn't it? Ain't they the first ones to start that, Nate?
So Cognitive FX is the research center I was talking about that does the functional MRIs. That's Cognitive FX, and I was 8 years with them in therapy development. It was kind of exciting stage, new research coming from the functional MRIs, and then, hey, therapist, can you figure out how to apply this and see what happens with the patients? So it was pretty fun and exciting at those stages. But that was when I started realizing because we had a lot of therapies, but they were still in isolation. Now, fortunately, they were back-to-back isolation. So you go to speech, and then you do some vision, and then you do some vestibular, but they weren't all at the same time. And so doing the occupational therapy side of things, I was comfortable with vestibular therapy, vision therapy, all of these things, because OTs are trained in all of those things. So I started integrating them and started coming up with the multisensory integration approach. There's no patent or copyright or whatever you would call it on that term. That's what we call it.
Well, let's patent it. Just kidding. All right. So we're going to go back to that in a minute, because it's fascinating, and they're wonderful. They're modalities, and you're intermingling, and you're getting the brain all the blood flow that you can and the engagement that you can all at one time. Now I want to ask Cristal, as a licensed therapist, somebody, and Nate mentioned about concussion syndrome 20 years after a head trauma. As a licensed therapist, do you, and I think you've actually changed some of your intake questions because of this gentleman to the right, to my right. But do you, obviously, prior, Corey, did you think to ask about, have you ever had a concussion? Have you ever had severe trauma? Have you ever lost a child? Had trauma can cause brain inflammation, can cause disengagement of certain parts of the brain, can cause. But have you changed some of your intakes and questions? And
Yes, 100%. Before Corey, we did screen for head injuries. Excuse me. We screened for trauma with our first responders and our veterans, as well as moms, dads, kiddos, siblings, from the vast traumas that we experience, whether it's physical, emotional, neglect. I didn't have any knowledge, really, just being completely transparent. I had no knowledge about CTE, TES, RHI. I've learned what all of these acronyms are and what they mean, and I continue to learn every day. What we implemented with our intake forms is specific questions about, for our veterans, what was your job? Mm-hmm. Did it involve? Mm-hmm. And then specific, and we've talked about this also, your head injuries. Does that make sense?
Yeah, absolutely. The whole, so then in the world of neurology, I mean, Nate, you know that it's been a long time coming, right? You said, 15, 20 years ago, okay, some of these therapies were enacted, but they were one here, one there. This multisensory.
Well, that's what it was like for me when I went to the concussion protocol. Is I did cognitive therapy, then I went and did physical therapy, then I went and did visual therapy, then I went and met with a therapist. So I was there 4 hours a day, but it was one after another. The therapy I do now weekly, I go and I stand on foam and they talk to me. And then I got to bounce the board back and forth.
As they're talking to you?
as they're talking to me. And then I try to balance on that board. And then I go over and they put cones down, and I got to step over a cone, look up, read a numbered card.
Mm-hmm.
Step, look up, read a numbered card, step over the cone. And I do that back and forth. And then they put me on a floating platform that has rubber bands to it. And I got to try to balance myself on this thing that wiggles.
Mm-hmm.
And that's where I want to come to you on your And then she massages me for like a half an hour to get the inflammation going. I get overstimulated doing that. And there's sometimes I can't do all of it. Oh, and I do leg presses. So on your multisensory integration therapy, for someone like me, like with repeated head impacts and everything that I've gone through, how do you control that simulation or stimulation of getting overstimulated to where all of a sudden, I've been at vestibular therapy at Samantha's and trying to balance on that board, and all of a sudden I can't do it and I'm getting pissed off, so I kick the board across the room.
That's normal.
He's been with me, and I'm trying to make copies of a resource
Jesus
for
Christ,
him
Minnie.
that.
Well, yeah, I mean, every brain injury is different.
So how do you work with that multisensory? Because like trying to make copies and talk to me at the same time, it ain't going to happen. You're going to piss me off and I'm going to get possibly violent.
Yeah.
Or very vocal.
Yes. We're not really afraid of that too much because there's always a grading it down to be easier level and still stimulate the same part of the brain option. And so what people end up doing, they would never guess that they would be able to do on day one in our clinic. And we wouldn't try it on day one in our clinic. You first want the brain to have task completion and get some of that healthy natural dopamine, from, oh, I can do this. You need the brain to be thinking, I can. And then we start introducing the challenges, just gradually bump up. And if you have a therapist that knows what they're doing, and this is why we just work with therapists, 90+% of the time in our clinic is with a trained occupational therapist. And so we're able to individualize and tweak things on the fly. So if I can see that we're exacerbating symptoms too much, then we're not hitting the just right challenge. We're overwhelming the system. If we under challenge, we're also doing no good. So you have to know how to give the just right challenge and go from the first introducing the I can, to then, oh my gosh, this is hard. I don't know if I can. Oh, I did it. Okay, I guess I can. And we want everything we do to be grading it up gradually so that we're able to start engaging multiple areas of the brain simultaneously without the person feeling overwhelmed. When I talk about it, everybody feels like, what? There's no way I could do any of that because, they get triggered pretty easy by things, but everybody does it. There's not really an exception almost coming to the clinic because we make it easy enough at the beginning.
So you, I suppose you navigate some of that because you navigate it so well because you have a one-on-one. Does a client have their own therapist for that 35 hours over 2 weeks? Or I think it speaks of this high amount of one-on-one, so that this therapist knows what you can and cannot handle, and knows your triggers, knows kind of the client, the patient very well.
Exactly right. There's some of the more popular approaches out there for traditional ways of dealing with this is using a multidisciplinary team, because, oh gosh, you've got a physical therapist and a speech therapist, an occupational therapist, and a vestibular therapist, and they're all getting a piece of you. And but when it comes to post-concussion syndrome rehab, you really want one person that can do all of those things and get to know you and the inside and out of what's going on with you. We're almost 100% one-on-one in our clinic with the therapist. So even after day one, you spend 6 hours of therapy with someone in one day, you'll figure a lot out, and you're going to learn a lot about them. And we do that day after day after day, and we're just changing things to fit that just right challenge. And you're exactly right. Like, that's what makes it so we can do that. I don't know that there's a way to individualize and have that just right challenge. If you've got a patient coming to you and you've got an hour to work with them and you haven't seen them before, so you're trying to figure that out. Like, okay, I got to figure you out. And by the time you figure them out, your time is half done, and then they go to the next person. And so I think you really want to bump thresholds as often as you can of the too little too much. There's that threshold. And when you are in that threshold for a high percentage of the time, doing many hours in a row, you start to have an effect on the brain. If you're under challenging, you allow the other compensating parts of the brain to keep doing their bad habit thing. They're just going to compensate. They're not challenged enough. If you do it too much, you override the system, and they don't benefit from anything when the challenge is too high. And so it really does have to be the just right.
This episode of the Head Rush Podcast is brought to you by our personal doctor and team of doctors, Dr. Mizelle DeMayo, and she's with the Paradise Behavioral Health, and we are in the
Brainwell program, which is also part of the Millennium Health Center. Dr. Mark Gordon, you've seen him on Joe Rogan and even on our show, the Head Rush Podcast, and hormones. And Mizelle is awesome. We love her.
She's our doctor of psychiatry. She works the Mark Gordon program with the hormones, and she adds her twist of genetics, and it basically is melding two wonderful mediums together, and we're getting great help from Dr. Mizelle DeMayo.
So please check out her website at paradisebehavioral.com. Look up the Brainwell program. Get involved.
She's sponsoring us. They're sponsoring us for the next year, so we are excited to have them on board and shout the good news to everybody that is watching these broadcasts. So,
is she helping you, Paul?
Absolutely.
She's helping me. So go check her out. ParadiseBehavioralHealth.com. And then you got someone like me that Samantha watches me from the time I walk in to the time I leave. Mm-hmm. Because I'll start doing an exercise, but I won't quit.
Yeah.
And she can tell by noticing me that I'm getting overstimulated, but I'm not saying I've had enough. I'm still going to do it and get on to the next one, and I'll start doing something. And next thing you know, the kid that helps me will say, Samantha said, no more. Just go to the dark room and back, and she'll be with you in a little bit. You're not doing no more. And it'd be like, what are you talking about? I still got to do my exercise. No, you're at that point.
Yeah.
Go to your room. And with what you're hearing now, Cristal, and I would like to come down and try 10 days with you. I don't, financially I can't, but I'd love to. Oops, sorry, Andrew. But matching you with what he's going, what are you hearing from what you see with me?
I'm going to start with what you just talked about with vestibular, how you just go and don't stop for that regulation. Thinking about what we do in therapy when we're working on whether it's the anger, the depression, the negative thinking, whichever one of those we're working on, one of the things that you struggle a lot with is getting your tasks done, your chores done, and not stopping. I said to you when we first started working together,
Meaning he has problems accepting that?
he doesn't stop.
He doesn't stop.
He does not stop unless someone is there to tell him, like,
Right.
is he a tech? Is he an assistant?
Yeah, he's a tech.
Okay. The tech says to you, she said stop, go to the dark room, you're done.
Right.
Right.
Or Susan says, stop, go to the house.
Right. If there's not someone there to regulate him, his history is so much about, this is what I've got to get done. I have to get A done. If I don't get it done, then I'm not helping, providing, being a good husband, whatever the thinking is. He doesn't know how to stop. So we've been working on breaking tasks up to avoid the overstimulation. Make sense? So to hear that that's what you do in there too, and she also sees that, thank you.
I suck at it.
Thank you, Jesus.
Well, that's
Yeah,
exactly
you
what
did.
Nate, you're saying, not too much, not too little. Because too much or too little is detrimental to the brain and the blood flow and the engagement, the re-engagement of the part of the brain that's shut down. So, he's at vestibular therapy. She notices that he's getting overstimulated. She understands too much is not good for Corey Berry. So,
Right.
and she says, let's shut it down. But the NCX is, okay, we're not going to shut it down. We're going to lower it to a point where you're going to be able to deal, adjust, work with it. And we're going to keep not pushing the envelope or pushing the limit, but we're going to keep engaging the brain.
Well, yeah, actually, we do reinforce brain breaks every hour and 15 minutes after we have engaged the brain. It's going to need more than just us making it easier enough for them to keep going. So we're going to push the envelope to about an hour and 15 minutes, and that's varied depending on each patient a little bit, but that's a general time frame. And then you've got to do a 20 to 40 minute brain break. And it's usually about 20, 25 minutes, but some need extra time. And the brain really processes information when you're in downtime. So when you're challenging, this is why all college courses should be different. And whenever you go to conferences, they do give you breaks sometimes if they're smart, but you really need some downtime between when you're trying to engage neural pathways or learn something new. All of that challenge needs to be broken up a little bit with brain breaks, some downtime. So they'll go in, we have a massage therapist, or we're all trained to do massage. I am a massage therapist as well. And so I've trained all the staff, and occupational therapists can do soft tissue mobilization is what it's called. But we'll work on the shoulders and the neck and do a suboccipital release, really help the neck muscles. Most people have whiplash or neck issues if they've hit their head a lot. And we want to rule out blood flow in and out of the brain needs to flow well by making sure the neck is loose. And so we do that as part of a brain break. And then we have a massage chair. They'll put headphones on. They'll listen to the ocean waves or, the mountain stream or whatever they like. And we do brainwaves. Brainwaves 37 is an app anyone can get on an iPhone. But it has 37 different modes, and they'll take you from the beta waves, which is when you're engaged and active. If you measured the frequency of your brain, it'd be up and down, really tall peaks. And when you go into alpha, which is where you really want to yet to process the challenge you just went through so that you're ready to do another one, you've got to get into that alpha mode. They've found that most memories encoded during alpha. So a lot of processing and making sense of what's just happened is having that downtime. And when we're in downtime, we're usually getting into alpha. But if you have post-concussion syndrome, you often stay in beta. So that's another problem with PCS is our brains don't want to turn off. And we get the people like you, Corey, who want to just keep going. And we have to, we first were cueing a lot. No, you got to slow down. But eventually we're like, Corey, you need to know when you need to turn it off. So we start training the individual on their internal cues, like how much can I do before I need to, even though I feel like I could do more, I need to be able to be the one that says, I'm going to stop and take a break. And
so can I practice this with them today? I'm going to be in Dallas the next couple days, and we can work on that.
Yeah, please do. Yeah, let me know how it goes.
Yeah, thanks.
Manage irritability.
As he's
levels.
flying back to Florida with a black eye and a bloody lip.
Better him than me.
Oh, gosh.
But it's crazy on... Now, someone like me, if I come to your clinic,
Yeah.
and you know that I'm TES and RHI and yada, yada, yada,
Yeah.
how would you approach if us at Head Rush Podcast had a guy and we said, hey, go to NCX and try this out? I mean, I wish I had the financial ability to go down there and do it and get a motel for 10 days and be able to leave my wife and dogs and everything. And you could ask my therapist, without my wife, I'm like, she's my crutch now since this accident. Yeah, I depend on her for a lot. But how would you walk someone like me through your clinic?
Yeah, someone like you walked in and you have TES, where they come in and say, I have CTE. And I'm like, well, you can't have CTE if you're alive.
Correct.
Because that's diagnosed by an autopsy. But, if someone comes in and that's what they're guessing they have, it's not like you have one or the other, like PCS, post-concussion syndrome, or TES. Like, you can have both, like I'm sure. So when they come in, I'm going to go through a symptoms checklist for post-concussion syndrome.
Well, that's what my medical coding is all over the place, is post-concussion. There's not a medical code for TES.
Right.
So I went to a CTE evaluation center at the Glenn Briggs Institute at UT Health San Antonio, a full-on CTE evaluation center. And Dr. Tanner's the one that said that you're clinically diagnosed TES, probable CTE. And for me, CTE no longer, I don't care about CTE right now, because the only way you're going to find out is dying. And I don't want to die to say I got CTE. I want to work on the RHI.
Yes, anyone who suspects CTE, in my opinion, should be doing PCS treatment, post-concussion syndrome treatment, because you likely have post-concussion syndrome. Maybe in addition to, and you wouldn't know till after an autopsy, but you don't want to wait around, and that's not helpful. So you want to be doing something that can make a difference. I will say, if you have some permanent damage in your brain, our second most served population are strokes right now, and they have permanent damage areas in their brain, right? And so they'll come in and they'll say, can you help us? And we've just started having so much success with them that we're very comfortable working with any minor strokes, especially. So, but the treatment would be similar to if you suspect, oh, well, what if I have some permanent damage? Well, that's neither here nor there when it comes to TES or CTE. Like, what you want to do is anything that might benefit and re-engage areas of your brain to work in a more balanced way. If you have post-concussion syndrome where you actually have zero permanent damage, it's like you have a roadblock. You're on a road driving, and you come to a roadblock, and there's a detour sign, and your brain's been taking the detour. A lot more energy, a lot more work. It's getting the job done, but you have symptoms and all of that. Your speed is not very good. It messes everything up. So your neural pathways are kind of like that. They get disrupted, and you're taking detours, doing a roundabout approach, getting the job done. Yet with PCS, we're fixing the road. We're reconnecting. We're helping those neural pathways re-engage with something where there's permanent damage involved, regardless of what it might be. It's like getting to that roadblock, and it's saying, okay, when you got to the roadblock and there was no detour sign, and you just started meandering around until you finally figured out how to get where you need to go. That's what's happening with a lot of permanent damage, because your brain has to, in survival mode, figure out how to navigate around disrupted neural pathways. And when it does so in a survival mode way, it doesn't usually do a great job of it. It's way less efficient than if you were to go through, think of normal neurodevelopment. It takes years to develop. And when you have to immediately come up with an alternate route in your brain to get the job done, it's not going to be very effective. So our stroke patients, they've graduated from traditional therapies because they can use the bathroom by themselves and they can get dressed by themselves. Some of them can even drive, but their quality of life is plummeted, because they still have all these issues. And so when we work with them and run through similar multisensory integration approaches with them, they respond really well and they don't recover 100% like a lot of our post-concussion syndrome patients, but they make significant progress because essentially you've now put a detour sign up and you've put several up, and you've helped the brain find an efficient way to deal with the permanent damage, if there is any.
So when you're talking stroke, I had 2 strokes 7 days apart, almost 8 years ago. It'll be February will be 8 years ago. And I think the first one was a TIA. TIA, is that it?
Okay.
And then the second one was the full ischemic. And I started, and Corey just reminded me earlier, I said the only word I'm having problems with sometimes is exclamation point. And he says, no, you're having problems with a whole lot of words. But you were talking about sometimes, so there's permanent damage, right? The left temporal lobe had the brain bleed. But 7 years after the fact, is NCX, does that program and that protocol, can that help in certain ways?
Yeah, for sure. Yeah. You have to remember, prior to coming to us, people have been all over the place usually because we haven't overly marketed ourselves. We're just so involved in therapy and everything that we're doing here. But they've usually been everywhere, and they've tried everything, and they've graduated from multiple, therapies and traditional approaches and what insurance will pay for, et cetera. So we're not really afraid too much of someone with a stroke coming in and not having a good experience, because almost all of them have noted significant recovery. I never promise a certain amount. I don't know what it's going to be. I just tell them almost every patient that comes in that's had a stroke, and we don't really do the moderate to severe strokes. We're not equipped for that level of things, but the small stuff. And if you come in and you have lingering symptoms, to this point, no one's done the right thing, so they still have the issues. It's a little more rigid to switch some of that in the brain. But 2 weeks is usually enough to make some significant progress there. I have had a few stroke patients off and PCS patients as well, but a few that needed more than 2 weeks. It's not like a cookie cutter, like everyone's the same, of course. So, we've had a few that have done 3 weeks. We've also had some that did 1 week because they only needed a little bit. But so we kind of have a range of what we can do. But almost all of them see progress with their symptoms because the only thing they've done is isolated therapies. And it's been a few hours here and a few hours there. You can do the exact right thing for your brain, but only do it for an hour instead of like we're 30 hours in 1 week, and they're getting 1 hour in a week. So your frequency is not enough. The brain is a creature of habit, and you're not going to change habits with just a little bit of therapy. And unfortunately, that's often what insurance will pay for. And so also, you need to not do compartmentalized therapy. If it's stroke or post-concussion syndrome or a myriad of other things where there's a lot of stuff going on in the brain, you need the whole brain to work together. And so a way more effective approach is doing something that requires multiple major processing areas of the brain to engage simultaneously so they're forced to work together and integrate. And when they integrate and work together, that's when things start improving. And we've reconnected neural pathways that have, not been able to just reconnect on their own or through these isolated therapies.
Are these constant protocols that somebody comes to NCX and for 2 weeks and then they go home? Or can they do the same exercises for an hour a day and keep that status quo, or they do it for 5 hours a day and keep improving? It's interesting. I was just talking to my father, 90 years old, and he says, "Paul, I'm still doing my sit-ups and I remember him doing it when I was a small kid, and because he has a bad back, but." He hasn't had a bad back for a long, long, long time, right?
Well, and it's like physical therapy and everything else. I've had 5 shoulder surgeries and neck fusion. I've had a lot of surgeries.
Mm-hmm.
The therapies are only for 6 weeks or 8 weeks or whatever they are. But your shoulder ain't going to get back to riding shape, or your body ain't going to get back to riding shape in 6 weeks.
Mm-hmm.
You have to keep doing it afterwards. And it's kind of like I go to vestibular therapy once a week, which I'm starting to understand from Nate that probably ain't enough for me. But I do stuff at home, but then I don't.
Mm-hmm.
Because I don't want to put myself in that bad situation. It's like last night, we're getting ready to move to Stephenville or Dublin. I'm not moving to Stephenville, I'm moving to Dublin. I had to load the trailer. I didn't stop. By the time I got in, I was overheated. I was almost loopy, and it's because I don't stop myself.
Mm-hmm.
And I was frustrated all day because the wife wasn't, what do we need to do? I need to get this done. What do we need to do? I need to get this done. What do we need to do? I need to get this done. And because I got atrophy of the brain, I got frontal lobe damage, I got large gray spots on the white matter of my brain. All this is proven over years of MRI. My spots are getting bigger, my my brain's getting smaller, and I got some separation starting. So, yeah, if I come to a place like you, it sounds like you look at me that has all of this and all this medical backing, and Cristal talking to you, of course, or whatever, that you're going to do the same type of therapy, but you're going to just cater it more of my symptoms to where, because I'm sure you don't want me punching out the guy next to me because he's talking too much. Welcome to the Head Rush Podcast, brought to you by the Patrick Risha CTE Awareness Foundation. Karen Siegel, thank you so much. Paul?
So go to stopcte.org, learn about their foundation, and they are sponsoring us for the next year. We are thrilled to have them team up with them and bring awareness to this disease.
So please go to their Facebook page, go to their website, check them out. Karen is very, very, very willing to work with you. Contact her, and if you do know her, thank her for us, or just go on their Facebook page and say thank you for sponsoring the Head Rush Podcast.
We might have to separate you from the other patients if you come.
He needs to be in a padded room by himself that's soundproof.
The little white jacket.
No.
No?
No.
Oh, no,
Stop.
I'm sorry.
Too far, Paul.
They're coming to take me away.
Too far, Paul.
What movie was that? Was that a Monty Python or something?
I think that's a Paul Fraze movie.
Sorry.
I don't watch movies. Y'all already know that.
Sorry.
So,
Paul, you started asking about aftercare, and then
Yes.
yes, to your point, Corey, when you come in, we would focus on working on more of a whole brain approach, like I've talked about. We would do many hours in a row, many days in a row. We got to satisfy that rule of habit in the brain. If you check that off, that's going to be helpful. We have an aftercare program because, in my opinion, any really good brain recovery program from this stuff should help the patient know exactly what they need to do for their routines, their hobbies, their interests, their work, maybe even choice of work, what they're going to do on the day-to-day basis for their life ever after that therapy. So when patients come to us, they'll have the 2 weeks maybe of our intense program, and then begins the 8 weeks of aftercare. We do an 8-week aftercare, and we want patients. There'll be a few things that resemble what we do in the clinic. There's going to be some cross-hemispheric activation where you're touching with your left hand, stepping with your right foot, and vice versa, while you're engaged in, word retrieval. And we have a few things that are going to feel like therapy a little bit, but they only take like 5 minutes a day. Our main goal is to maintain everything that we gain. So if you've just reset some things and connected some neural pathways, the last thing you want is to lose any of that because you haven't satisfied the habit rule yet. And so we've done it enough hours in a row. We've created the habit. Now we want to maintain the habit. The 8 weeks of aftercare is about maintaining the habits and the progress that someone's made. And then it's also on targeting any areas. If they're a 75% recovery, let's say 75% reduction in symptoms in the 2 weeks. No one's like, okay, I'm done. I'm good. I don't need any more. Most everyone's super excited because now they realize progress is possible. And so we're shooting for that 100% usually with everybody. And so that aftercare is also not just for maintaining, but it's also building on the progress they still have to make. And ultimately ending with lifestyle changes, and they need to be connected to what you would want to do anyway. Like hobbies and interests and routines all need to be something very individualized to each person. So we do that at the end of our 2-week program. We have very detailed meeting. I've got 2 of them today. I'm going to be doing with patients where we're just creating a program for you. Like, this is what you need to do for the next 8 weeks. And then parts of that you're going to do for the rest of your life, probably, because you love it, hopefully. And it also happens to be brain healthy. If you can do things you love that also happen to help your brain go where it needs to go, then that's the best. So
That's great.
can you get me back to team roping?
Can you?
I don't know if I get your body back, but maybe the brain. I don't know. What's your body like?
He's in shape. He's in good shape. But you're stretching me, Nate. So you're saying that I'm going to be able to walk and chew gum at the same time. And
Yes.
okay, all right.
Yeah.
Well,
Yeah.
This has been great. I mean, I've learned.
Before we close out, I want to give them a nice little plug.
Go for it.
Here's a little plug for NCX. 80% of concussions improve and recover within days or weeks of a trauma. 20% are left looking for answers and generally bounce from doctor to specialist endlessly until it feels like the answer is to accept the new norm. At NCX and even Cristal, accept the new norm. Right there, accept the new norm. At NCX Brain Recovery, we work for complete improvement and healing. 90% of their patients report significant improvement in their post-concussion symptoms, with many experiencing full recovery.
And that's 90% of the 20% that don't that actually have that post-concussion syndrome. So those are pretty darn good percentages. So, Nate, a lot of information, love it. A lot of new information for me. Some of these things I've never heard.
Me too.
Yeah, it's been great, and
Yes.
thank you. We always end with a word of hope, and I would love for you to share a word of hope for our audience.
Sure. Gosh, I'm glad you asked for that, because to be honest, a lot of the concussion news and stuff out there is not the words of hope, right? The things that make the news are kind of the bad stuff. So I'd love to end on a hopeful note. There is a ton of hope. I smile when patients come in. I'm just like, I can see how much you're suffering, and I am already excited for what the possibilities are for you. And people who are suffering with brain fog and headaches and dizziness, and I mean the list goes on and on. If you've hit your head and you have symptoms that have not resolved, most likely they can be resolved. And I think that's a pretty awesome thing to figure out, and full recovery is what we mostly see at our clinic. So yeah, if you're suffering with that stuff or any brain related condition, we've seen so many improvements. We've had some that have come in that have never hit their head, quite a few actually, and they just know that their brain is involved somehow and it's not working right. We don't even always understand what it was that was going on, and I won't usually recommend treatment. I leave it up to them. I say I'm glad to try to help you. And there's just very few, if any, intense approaches to brain recovery because of the parameters of insurance and people's time and money and everything. There's things that get in the way. But if you really want recovery and you do it the right way, it's definitely possible. So it's a kind of a dream job, seeing people's lives change, come in, and they are on just the verge sometimes of suicide. Even it gets that bad, a lot of the time, and they come out. We hear over and over, like, you gave me my life back, and there's just nothing greater. It truly is a therapist's dream job for that reason.
Wonderful.
So how do they reach you, Nate?
ncxbrainrecovery.com. Just go to our website at ncxbrainrecovery.com. And free consultations is where we start. We've been able to still do that and not be too overwhelmed yet. So we still just want to make it free at the beginning. And so you basically have the opportunity to get some expert advice on what's going on with you and what we would recommend. And there's times I also send someone somewhere else because I don't suspect post-concussion syndrome. And so it's but it's a good stopping point to go if you suspect, I hit my head and now I have stuff after that. And I wonder if they could help me, or if you've had a stroke or anything else that's been unresponsive to traditional approaches or medications or whatever. we can talk and get an idea just by, we do a virtual consultation, and we just have a conversation virtually, usually, because most of our patients are out of country or out of state. And so we'll just do it on the computer. It's free, and we can help you figure out where to go from there. But that's the best place to start.
Great. Do you accept insurances like Blue Cross Blue Shield, or are you like
concierge medicine?
or
That's
we document for, and we will bill insurances like crazy, but they won't accept us often just because of they're used to paying for an hour a week, and we're doing 30 hours in a week. And so we've had some success getting some paid for. Other insurances won't pay any. It's kind of a frustrating point for us right now, because people will bounce all over the place for years and not get what they need until they finally are able to come and afford to come. And we try to make it more affordable, but it's still a chunk at one time because you're doing so many hours in a row in 2 weeks, or whatever. So, but it is something that I hope that can change, that we're definitely pushing that insurance envelope, trying to get them to open it up.
Nate Pope, thank you very much for joining us. Nate is the co-founder of NCX Brain Recovery, and they have a groundbreaking multisensory integration therapy. We have learned so much today. Thank you. And we'd love to have you back on in the future, and we'd love to track your progress. And you might see one of us or both of us out there soon in Utah. So
only if he promises he can get me back team roping or snow skiing.
Ooh, good. All right. Hey, the Bunny Hill is easy enough. We can get him back on the Bunny Hill.
Yeah, we'll talk.
Great. Nate, thank you.
much.
Sir,
Word of hope.
I think we are created for community, and if we live in community, it makes sense to also heal in community.
Mm-hmm.
Integrated treatment is so effective. Everything that they're doing out there, it's integrating your systems to heal. Community, find your people. Try not to isolate, because,
I do a lot of isolating.
I mean, okay.
You
do?
You need to go out and take some walks.
Ground yourself.
Breathe. Ground.
He does. He does.
No, I'm just totally kidding. Corey is. I'm very impressed. We met about a year ago.
Right.
Mm-hmm.
And you said you had a tough day yesterday, and you've been absolutely incredible today. I see Corey Berry in front of me, not Corey Berry down and out. So I
even did TMS this morning.
Right.
Exactly.
It really, there's been some very noticeable changes that you're staying in that window of tolerance longer.
I don't know.
But
Yeah.
I know. But
We'll tell you.
We'll tell you. Yeah.
My short-term memory is like gone. Will your brain recovery help me with my short-term memory? Will I be able to remember your name in an hour?
I don't guarantee anything, but memory almost always improves with.
Well, that's exciting.
Thank you so much for coming on, Nate. I appreciate it. And you may see both of us down there. We may give it a try. Maybe he'll give us the Head Rush promo or
the brother-in-law promo discount.
The promo discount. We'll run a commercial one.
Absolutely. Well, yeah, we're excited, and we're pulling for everything that NCX is doing.
That you're doing. You
Yeah.
sound like it's really working and things are going good and you're making a lot of sense. So thank you for coming on and talking to us, and appreciate it. Thank you.
Yeah, thank you guys. You guys are fun to talk to, and and great hosts. So I appreciate it.
Awesome. Thank you, Nick.
All right. Thank you.
Yeah, we'll see ya.
Another great episode
I,
to have on and talk about modalities, therapies, and things that we can do to improve our lives while we're out here dealing with our struggles. That me and you both, we have multiple issues. You've had stroke and repeated head. I've had a major head trauma and repeated head impacts, you know, and we got our therapist right here that's can look at us and go, you both are screwed.
No, she fixed me after the first session. So, but
Yeah, that's why you were wearing the tappers on the way here today, right?
that's all right. EMDR. Yeah. So, thank you, everybody, and stay alert, stay alive, share, subscribe, get the word, follow, get the word out, and we're about awareness, we're about hope, we're about and one of our previous episodes were about facts too, because there are modalities out there that work. Period.
Andrew Marr says that there's no hope. It's all facts. It's fact that you can get better.
In some the things that he did to get better.
Right.
Absolutely.
There's facts that you can heal a brain. It's just a matter of doing it.
And create your community.
And I'll tell you what, when it comes to community, I got to say I got a great freaking community. Between my neurologist, my vestibular therapist,
Your
my
wife.
counselor, my wife,
Yeah.
you, and other friends. And maybe Nate will become our next member
Community.
community. He'd be the furthest one out.
I've never been out to Utah other than the Four Corners at one of the Navajo reservations we were working with. We did a football camp out there years and years ago when I was at the Jets. But beautiful country out there, and yeah. If you have a spare room, we're on our way. So
Coming out, I'll kick one of the kids out of their rooms.
okay, good.
I get top bunk.
I do have a bunk bed, so you can both come.
Perfect.
There you go.
Perfect. Good. All right.
All right, thank you.
Thanks, you guys.
Stay alert and stay alive.
This podcast is for general information only and does not constitute the practice of medicine. The use of this information and the materials linked to this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard and delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.